Good evening. I'm Judy Wasserheit. Can you hear? Yeah. Okay. Great. Good evening. I'm Judy Wasserheit. I am the chair of our Department of Global Health here at the University of Washington and the co-director of the University of Washington's MetaCenter on Pandemic Disease Preparedness and Global Health Security. And on behalf of my partner co-director and all of us involved, my partner co-director Peter Rabinowitz, and all of us involved with the MetaCenter, it is a real pleasure to welcome all of you who are here in the room and those of you who have so patiently waited for live stream connection. Thanks to very generous support from Ty Kramer, who is a member of our Leadership Council in the Department of Global Health, we are here this evening to discuss what we know, and equally importantly, what we don't know and what we need to know about the new coronavirus and the health problems that it can cause. We're here to answer as many questions as possible, to explain what's being done locally to protect people right now, to share some of the research that's going on to develop and vaccines and improved diagnostic tests, and to help connect both those who are already working on this problem and those others who might want to help. This virus has been moving very quickly. It's been less than 8 weeks since that first cluster of about 40 cases was reported in Wuhan, China. And in that period, there has been an explosive epidemic that's resulted now in about 75,000 confirmed cases, depending on exactly how you define a case, and about 2,000 deaths, the majority of both still being in China. And we've also begun to see profound social and economic impacts around the world. The good news is that the science has also moved with unprecedented speed. So in days to weeks, rather than the usual time frame of months or more, we have seen a new virus identified, diagnostic tests developed, and there are many treatment trials that have already been started, more are planned, and multiple groups are working on vaccine development. And you'll hear a little bit about some of this tonight. I think equally important, global communication has been extraordinarily rapid and robust with this epidemic. I think the other piece of good news is that currently there are still relatively few cases here in the United States, and the risk of becoming infected remains low here in the United States. Preparedness and response efforts have been pretty strong to date, and Washington has actually not only been the home to the first U.S. case, but has become a national leader as part of this response, and that's thanks to the efforts of many people, including some of the people who will be speaking tonight. However, epidemics, particularly of new viruses and new diseases, can be very frightening, and that fear often gets translated into stigma and discrimination, which means that the need for timely, accurate, evidence-based information is just as urgent and essential as the need for effective drugs and vaccines, and that's part of the reason that we're here tonight. Epidemics like this require an ability to manage pretty serious risk in the face of uncertainty and incomplete information, which is pretty uncomfortable, actually. At times, it means navigating the balance and the trade-off between the safety of populations and the privacy or freedom of movement of individuals. And it can require communities to come together to make very tough choices in order to make sure that as many of us stay healthy as possible. I'd like to make one last point that I think all of us should be thinking about as we talk tonight. This coronavirus epidemic will not be the last one that we face. In fact, it's more likely to be a preview of our future unless we start to do something differently. The frequency, severity, and magnitude of outbreaks of organisms with pandemic potential has increased dramatically in the last 40 years, and they've increased because of changes in the way we live, including the way we interface with animals, the way we use land, the way we travel, the way we change our environment. And that means that we need to fight this battle on two fronts at the same time that we need to contain this coronavirus epidemic. We also have to strengthen our ability to prevent, detect, and respond to much more broadly to new and re-emerging infectious diseases with pandemic potential. And we have to do that using cutting-edge, innovative approaches and working very closely with our colleagues in low and middle-income countries where these outbreaks tend to emerge. So that's exactly what the MetaCenter is about, and one of the reasons that we're all here tonight. So with that, let's get started. Both the University of Washington School of Public Health and the School of Medicine have been very involved in the response to this new coronavirus. So I'm particularly delighted that Hillary Godwin, who is the Dean of our School of Public Health and a professor of Environmental and Occupational Health Sciences, and Tim Dillett, who is the UW Medicine Chief Medical Officer and Professor of Medicine, are here to join us to open this forum, and to share a few of their thoughts. So Hillary, please, will you get us started?
So I wanted to start by saying thank you to all of you for coming and joining us tonight, and huge thanks to the MetaCenter folks for organizing this event. I also want to make sure that we thank our public health practice heroes from the local health departments and the state health department who have made time out of their already very full and busy schedules to be with us here today. These folks have been on the front lines responding to rapidly changing containment needs and making sure that our communities are prepared for future possible cases in this region. And I know I personally sleep well at night knowing that you guys are out there working for us. For us at the University of Washington, the outbreak has brought to the forefront a question of what's the appropriate role for academic health science schools in a public health outbreak like this one. We feel very blessed in the University of Washington School of Public Health to have such great collaborative relationships with our state and local health partners. And you'll hear more about that in the second panel and how we've been able to leverage that. But we're still left with the question of how can we do more? And so as we move forward, hopefully after things calm down a bit, we hope to engage with you guys in conversations about how we might better engage folks from across campus in helping all of you on the front lines and leveraging not only places like the MetaCenter, but initiatives like the Population Health Initiative. So with that, I turn it over to Tim.
Good evening. I also want to extend my thanks both to the MetaCenter as well as everyone who is here in person and those who are streaming online. I also wanted to follow up on something that Judy mentioned. And I think back as an infectious disease physician when I came here to University of Washington for my fellowship and what has transpired since then. We've had SARS in 2003. We had 2009 H1N1 pandemic influenza. We had MERS in 2012. We had Ebola in 2014, and although that may not have had the same pandemic potential, from a resource intensity and preparedness, it really caused a lot of us to spend a lot of energy and well-spent energy because much of what we did in preparation from 2014 has carried forward to our preparation here for now the novel coronavirus in 2019. And so I suspect absolutely we're going to see more and more of these potential emerging pathogens. When I look at the lineup tonight, it really strikes me how fortunate we are to live in the Northwest. We have wonderful healthcare systems. We have tremendous local health, public health jurisdictions, particularly here in King County, but also our partners in Snohomish and the other local surrounding counties. We have wonderful partners with the Department of Health. And we also have the Northwest Healthcare Response Network that really helps coordinate all of our activities across our various healthcare systems, ensuring our preparedness and particularly communication. I also think we're very fortunate when you look at the University of Washington and the breadth of our activities, both locally in response, regionally, and then globally, as has been mentioned here as well. From a School of Medicine standpoint, we have wonderful clinical care and in coordination with public health, great epidemiology, along with all the other health science schools within the University of Washington. We have tremendous research, and we're going to hear more about that innovation during those panels as we think about emerging pathogens. And we also have tremendous education, and the education is also very important to me as I reflect on one particular individual who is with us today, Dr. George Diaz, who is our guest from Providence, Everett. George was an infectious disease fellow with us many years ago. And from my standpoint, one of those fellows that I very much regret that we weren't able to keep within our system, but also strikes me the importance of our role in educating the next generation of physicians and the leaders and partners that we have within the community, as they did an exceptional job in caring for the first patient who was seen in the U.S. with this novel coronavirus. So again, thank you very much for participating this evening.
Thank you both. All right, it's time to get started now. We're going to hear from 3 panels of experts, focusing first on how the virus spreads and causes disease. Then we're going to talk about the response to this novel coronavirus and future outbreaks with pandemic potential. And the third panel will focus on emerging insights and innovations through research. Each panel will be in a Q&A format, starting with the panel itself and then your questions. And each one will be moderated by one of the leaders from our MetaCenter. In the interest of time, I'm going to introduce everybody now, so you don't have me coming back and forth up here. That's more time for questions. So the first panel will be moderated by Peter Rabinowitz, who is co-director of our UW MetaCenter, as I said before, and professor of global health, environmental and occupational health sciences, and family medicine. And he also directs the UW Center for One Health Research. The second, actually, do you want to wave so people know who you are? Okay, there we go. Thank you. The second panel is going to be moderated by David Pickett, who leads the Vulnerability Assessment Group of the MetaCenter. And he is an assistant professor of Health Metric Sciences based at the Institute for Health Metrics and Evaluation. And the third panel will be led by Wes van Voorhees, who leads our MetaCenter's Biomedical Intervention Group. He is a professor of medicine and infectious diseases, and he is also the director of our Center for Emerging and Reemerging Infectious Diseases. After these three panels, we're going to have a closing session, which will give time for a few final thoughts and additional cross-cutting questions. And that session will be moderated by Beth Bell, who served as acting director for the MetaCenter until fairly recently and continues as our senior advisor. She is a professor of global health here and is the former director of the CDC's National Center for Emerging and Zoonotic Infectious Diseases, so has longstanding experience in this arena. And with that, Peter, the podium is yours. Here we go.
So thank you, Judy, and thanks you all for coming out tonight and for everybody watching this online as well. So I'm Peter Rabinowitz. I'm the co-director of the UW MetaCenter for Pandemic Disease Preparedness, and I'm going to moderate this first session. The goal, as Judy said, of the first session is to really set the stage with some latest information about the COVID-19 infection and the virus that causes it, and how that acts when you're actually taking care of a patient with it, and how you are also how it is acting in populations as opposed to just a single patient. So I'm going to introduce the panel that's going to be talking about this, to talk about the virus itself and coronaviruses in general. Dr. Jeff Gottlieb is an infectious disease physician, professor of medicine at UW, and he's also the interim chair of the UW Advisory Committee on Communicable Disease, which is really leading the response to COVID-19 across the UW campus. And George Diaz, as you already heard, is an infectious disease physician trained at UW, and since 2005 has been an infectious disease specialist at Providence Regional Medical Center in Everett, and he was the treating physician for the patient who was hospitalized in Everett with COVID-19. And Kathy Lofi is the state health officer and chief science officer for Washington State, and she advises the governor and the secretary of health on a wide range of health issues, and her particular interest is in infectious disease outbreaks and their control. And she will speak about populations. And before I ask them some questions, I just wanted to talk about one other aspect of this situation that Judy alluded to, which is that we have seen in the last several decades more and more of these what we call emerging infectious diseases we've really never seen before, or diseases that we maybe knew about before but are acting in totally different ways. And these emerging infectious diseases, when you add them all up, and there's been MERS and SARS and Ebola and West Nile and avian influenza and H1N1, when you add them all up, actually about 2/3 of them end up being diseases that come from animals. And there's really something going on, as Judy said, about the way we're interacting with animals that we still don't quite understand when it comes to COVID-19, but it's going to be very interesting, important to understand it, because the other coronaviruses that you've heard about that the COVID-19 is related to seem to have really fit this pattern of coming from animals originally. So that in 2002, when SARS broke out in China, it broke out in the midst of live animal markets where these civet cats were being sold for food and had been bred in numbers that had never been bred like that before. And the workers in the markets were some of the first people getting sick. when in 2012 another coronavirus that, just like SARS, appears to have actually had its origin in bats, started breaking out in the Middle East. It was in camels, and people worked closely with camels, and somehow the virus had jumped from bats to camels to people. And it turned out that we're also now raising camels in ways we never raised them before, much more intensively in barns all close together with people working together like that. And now we have this COVID-19 breaking out again in the setting of a market. We don't know everything about what happens. We really need more research about what exactly happened to start this whole problem. But there were markets, and there were animals being sold, and there was lots of intensive farming of animals happening. And I think we need to really learn the lessons of how we're interacting with animals as we try to feed a growing global population, that COVID-19 is, and the animals are trying to tell us something, and hopefully we'll learn that lesson as we learn the other lessons that we need to learn about how to respond to a problem like this, but hopefully be able to prevent the next one as well. So I'm going to turn now to our panel and ask Jeff to really kind of just describe what is this coronavirus like? How is it different from other coronaviruses, and what is it doing to produce this infection of COVID-19?
Great. Thank you, Peter, and thank you all for coming. So my job, I hope, is to just give you some information about coronaviruses in general and what's new about this particular novel coronavirus that emerged a couple of months ago. As many of you may know, coronavirus is a large family of RNA envelope viruses that circulate in animals primarily, but also in humans. There's 4 human coronaviruses that have been with us for a long time that cause the common cold, and maybe 5 to 20 or 30% of colds every year in you or your kids or your family members are due to these human coronaviruses circulating. They cause relatively mild disease. They're ubiquitous on the planet, but they really have a very low case fatality rate, and at most they keep people, out of work, and hospitalizations and mortality is quite rare. And as everybody's alluded to, we've now seen 3 animal to human spillover coronaviruses over the last 15 years or so, since 2003. SARS, which was first recognized in 2003 out of China, probably went from bats to civet cats to humans. The epidemic spread to other parts of the world in many countries, including North America. In total, about 8,000 total cases globally, with a case fatality rate of about 9 to 10%. And then, about a decade later, we saw MERS, which is still sporadically spreading around the country, started in the Middle East, as Peter alluded to, started in bats and then went to camels and humans. Fewer cases, about 2,400 globally over the last 7 or 8 years, but with a very high case fatality rate of about 35%. And now we have this new novel coronavirus that has gone under a couple different names: COVID-19 for the disease, what's been renamed SARS-CoV-2 as the actual virus name. As Judy alluded to, there's been now at least 75,000 cases worldwide, with a case fatality rate estimated at about 2.3%. Those numbers are very rough, and we're still learning a lot about how this virus spreads and what its pandemic potential is. Typical disease features, which I think George will talk about more because he has obviously firsthand personal experience, but fevers, respiratory symptoms, pneumonia, in severe cases causing acute respiratory distress syndrome and requiring intensive care, ventilator support, and in those patients often leading to high rates of mortality that progress. Those symptoms are relatively nonspecific for viral diseases, and we're still learning a lot about the specifics of how this virus causes pathogenesis and how easily it spreads. But clearly, based on what we know so far, it is spreading person to person relatively, seemingly easily, at least in China.
Great. So, George, could you really just tell us kind of what it was like to take care of the first U.S. patient with COVID-19, and what are some of the things that was going through your mind as you were doing it, and what did this disease seem like when you were actually treating?
Right. So the large portion of the work that we did actually happened before the patient arrived. When the Ebola outbreak happened in Africa in 2014-15, our hospital began sort of becoming ready for it by setting up a system where we could accept patients with Ebola. That required monthly trainings to make sure that our staff was ready, to make sure that our partners in the community were ready to transfer the patient from one location to another, to set up our unit in our hospital rapidly and safely with our facilities folks. So all of that preparedness happened well before the patient actually arrived.
I think the mic's picking you up well. Just move it a little closer.
Is that better? So most of the work that we did happened, over years before the patient arrived. And so when we got the call from the CDC that we had a positive patient, the first thing that went through my mind and our infection prevention manager's mind was, okay, do we open our unit or not? And we thought that since we had recently done training on this, actually a full drill a few weeks earlier, that we knew that we could get all our protocols and procedures in place and do it reliably so that we would be able to safely accept this patient. So we decided to open our unit. And once we made that decision, then we started going through our checklist. And that's really what was on my mind, to make sure that we had all the pieces in place, all the nursing staff that is a volunteer staff, come in, have all the facilities folks come and build the walls that we were building to wall off our unit, to test the airflow in the room, and to make sure we all had all the supplies necessary to care for the patient. We also had to communicate with the EMS folks to make sure that we could safely transport the patient from his home to our unit in a way that wouldn't cause panic in our hospital. So we had them come through some loading dock doors and transport him through a part of the hospital that was lightly used, so there would be no other patients or visitors seeing the transportation of a patient who's got a highly communicable disease potentially. And then we just got him in the room. At that point, we started focusing on the patient and making sure that we were providing him support that he needed to get all the supplies in the room. We used a telehealth system to be able to examine him and talk to him. The nurses were in the room, but we wanted to limit the number of folks going in the room. So we had a computer set up with a screen and a monitor so we could interact with the patient outside the room, limiting the number of folks going in there. After that, we just took care of him supportively. There's really not any specific treatment other than maintaining his fever, making sure he's eating and hydrated, and really didn't have issues until about a week into his illness when he developed pneumonia. At that point, we made a decision with the CDC to administer remdesivir, which is a novel antiviral that's currently in clinical trials, and he had a fairly robust response relatively quickly. Before that time, we'd also noticed that his liver became inflamed, and that appears to be a somewhat common phenomenon in patients who have coronavirus, is that it seems to be correlated with the development of respiratory distress. And after about 24 hours of giving him this medicine, he improved rapidly. So we were encouraged by that, and he's now back home and out of isolation. So we're very happy about that. I think the course of our patient is fairly typical. Of the 15 patients that have been in the U.S., 5 have been able to stay outside the hospital. The rest have been in the hospital, and most have developed pneumonia. So I think this is a common feature for this virus. And thankfully, no one's really become critically ill in the U.S., and there's been no deaths so far. And that's a little different from what the experience has been in China so far. So hopefully, our supportive measures and the way we're caring for patients here is making a big impact.
Great. And Kathy, as this was happening, there was beginning to be, the public health system was going into high gear, and you were thinking about what the pattern of spread had been in other countries. And so what's your take on how it seems to spread in a population and what to be prepared for when you're doing that?
Right. So first of all, thanks for having me, and good evening, everyone. Just to follow up, I think, on some things that George was saying, our first priority when we found out about the case was to, make sure that the case was getting adequate medical care, which we did. And then our second priority was really trying to identify contacts who the individual may have come into contact with. To see if there was spread to anyone else in the population. And this was a little bit challenging because it was a new disease. As you mentioned, we were trying to figure out, okay, well, how is the disease spread? Because that helps us determine who is at risk for getting the infection. And so we worked with the CDC and, really decided to, make a lot of assumptions based on, other coronaviruses. So coronaviruses in general are primarily spread through what we call droplet spread. And that is when, people cough and sneeze. They can have respiratory droplets that, can come out of their mouth, generally land within about 6 feet of the individual. And if those, get into the mucous membranes of somebody else, then that person can become infected. So we based, our contact investigations on that assumption that it was spread primarily through droplets. And so we tried to identify everybody who this person may have potentially exposed. And in the end, we identified about 77 individuals who may have been at some risk. And then what public health does is we follow these individuals. We monitored all of them for 14 days. If any of them developed symptoms, we got them tested for COVID-19. And fortunately, none of the contacts that we identified ended up developing the infection, which was, I think, really good news for us here. The other thing that we did to try to learn more about this particular virus and how it was spread is that we did what we call an enhanced contact investigation. So with the help of a team from the CDC, we asked these individuals if they would be willing, even if they didn't have symptoms, to be tested for the virus. And about 26 of them did, agree to be tested, even though they didn't have any symptoms, and all of them tested negative as well. Because we were starting to, trying to start answering some of the questions that we had, like how is the disease transmitted, and can people have an asymptomatic infection, and can an asymptomatic person spread the illness? Some of these questions that we're kind of grappling with now, we tried to start answering, through our contact investigation.
Great. So kind of turning to the university where we are now, Jeff, can you say something about what it's been like to handle the situation in the university? What sort of possible cases have popped up here, and how has it been to handle that?
Yeah, sure. So as you all know, the university is a huge place with about, we have 3 campuses here in Seattle and Bothell and in Tacoma. We have about 100,000 members of our community, students, staff, faculty, ancillary folks, and that's a kind of a small city. And so thinking about managing an outbreak like this on campus presents a lot of challenges. As Peter alluded to, there's the Advisory Committee on Communicable Diseases, which tries to coordinate responses to outbreaks on campus and has a long history of doing that over the last few decades. Early on, we learned from our colleagues at Public Health that we had a few patients who had traveled back from Wuhan, China, or a few students who had traveled back from Wuhan, China with symptoms. To date, we've had 4 in all who were persons under investigation, and they've all tested negative. The challenges of them was, finding out who they were, getting them appropriately tested. If they were living in communal living situations, which many of our students are, in dorms, in shared apartments, and fraternities and sororities, things like that, getting them to a place while we were waiting testing to get them out of communal living situations, and that can be a challenge in such a big campus. The campus fortunately does maintain some isolation unit housing on a limited basis that we were able to move folks to sometimes as needed. And then just coordinating with all the messaging with the greater campus community about what steps we were taking, anticipating more cases coming down the road, and working with leadership communications, our medical colleagues at UW MetaCenter and our colleagues at Public Health. Jeff and his group at Public Health have been indispensable helping coordinate campus campus coordination of these 4 cases, and I think we learned a lot about how to, with these 4 negative students, how to learn that. We've also looked at travel. As you can imagine, with such a big campus, we have lots of faculty, students, and staff traveling to the affected areas in China and learning about their travel plans to come back. As you probably heard if you're a member of the campus community, that the university put a travel ban for UW travel-related business to China until this dissipates, and trying to figure out who in our campus community might be coming back and might be at risk, and trying to make sure they are tracked, staying at home, and not potentially spreading a virus to the rest of the community. And so that's taken a lot of partners, both in upper campus, in UW Medicine, and our public health colleagues.
So we want to leave time for questions, but I just wondered briefly, George, could you just say something about what's happened to the patient, and how did you know when you were done treating?
Right. So the patient is doing well now. He's back at home after his fever's resolved. He felt much better, and he was off of oxygen. We worked with our county health department to get him back home. He wasn't yet out of quarantine, and so he had to stay home by himself. The health district would bring food to him and make sure that he was well cared for at home. And then while he was there, they did serial testing on him to make sure that he was no longer shedding viral RNA that potentially could be contagious. And so thankfully those tests have now come back negative on 2 separate occasions, and he's been released from quarantine.
Great. And Kathy, could you just sort of give a snapshot of where the health department is right now and what you're expecting in the near future in terms of everything going on in public health?
Yeah, so after we, helped to manage the initial patient, several of you have probably heard in the news about some new measures that our federal government put into place. Currently, they are funneling all passengers who are traveling from China to the United States into 11 different airports here. Seattle, Tacoma is one of them. When travelers come in, they do get screened for symptoms, and then their names and contact information get handed off to the local health department where they live. And the local health departments have been helping these individuals monitor their health, and asking them to stay at home away from others for the 14 days after they return. So that has been a lot of, after the first case sort of settled, we spent about a week and a half just getting that system up and running. We currently have about 750 individuals who have recently returned from China, who public health has attempted to contact, and who have been asked to monitor their symptoms and stay at home and out of school.
Great. So with that, I think we're going to open it up to the audience for questions, and we were going to take several questions and then have the panelists answer some of those. So I think we're going to have a mic that people can come up to the mic and ask a question. Any questions for these panelists? So you can pass a mic or have you come up to the mic. There's a mic standing here and there's one here. So do you want to try to come up? We'll take the first 3 questions and do some answers and see how much, if we have any more time.
In regards to fecal spread, that tested positive. Where do we go from here? Are we looking at investigating more of the 261 that are under surveillance, supervision? How long have they been back? I'm taking it that those aren't, of the 77 of the first, we're now, the 761 are travelers, is that right? Inbound? And they're about a week now watched?
Yeah. So why don't we try to take talk about that, and you want to ask another question? You want to put your question out? Yeah. We're going to try batching the questions in threes and see.
Question for, I think, Kathy Lofi. I understand that there's going to be routine testing for, COVID-19 or whatever, the coronavirus, on flu specimens that are negative for flu. And I was wondering if you would fill in a little bit more information on where these things are going to be tested and how many.
Okay, and one question over here.
Yes, I actually reviewed the case study of the first case in the United States, and I'm wondering that what's the difference, like a symptoms difference between like a SARS, MERS, and the COVID-19s? Yeah, because our community really are very afraid of this virus, and they have these questions.
Okay. So, Kathy, do you maybe want to start? And then
Sure. I think I'll start with the last question, which is about, how kind of our next phase of surveillance is what we call it in public health. And that's really detecting, how do we, track the virus out in the population. And we are in conversation now with some of our local health departments about how we could start doing some routine screening to try to determine, if the virus may be spreading here. We don't think that is the case now. One of the problems that we're dealing with is the testing capacity. CDC has developed an assay. That assay has not been released to the states yet. It was released. There were some issues with the assay, and we are waiting to get the assay back again so that we can start doing testing here in Washington, because currently the only laboratory in the country that can do testing is at the Centers for Disease Control. And then the other issue that we're trying to work through is that when the assay was approved by the FDA, there were very strict specifications in the emergency use authorization that said how the assay could be used. And it was really supposed to be used on people who have symptoms. Symptoms that meet the CDC case, the kind of the criteria that CDC looks for. So we need to think a little bit about, how we can, do testing. But so plans are in place, but it's going to be a little while yet before we're not exactly sure when we're going to get the assay. And then the second question about fecal spread. So the coronavirus in general rarely can be spread through fecal spread. I don't believe it's supposed to be something that can occur rarely. So it's something I think we need to keep in the back of our minds. And then I think the other question was about the travelers. And so there are about 750 travelers who have returned from China, and we are monitoring them in different ways. If they have returned from the Hubei province, they are, they need to stay at home and really cannot leave their house at all. If the other travelers that are returning from other provinces in China are asked to stay at home, not go to work, not go to school, and to monitor their health for 14 days. And if they become ill, we will get them tested for COVID-19. Did I answer them all?
And yeah, the difference between symptoms between
Flu and
SARS, MERS, and things. Jeff, or George, do you want to speak to that?
So I think the symptoms are relatively similar. People present with upper and lower respiratory tract symptoms, fevers, pneumonia. I think the key differences between the three viruses, the amount of people with severe or fatal disease. And although we don't know what the final number is going to be for COVID-19 disease, that appears to be relatively low, maybe 2% at current estimates from data coming out of China, whereas SARS, the case fatality rate was about 10%, and for MERS, it's about 35%. So although the syndrome people present with and clinically look similar, the disease severity appears to be quite different. And it may be in the end that COVID-19 disease has a lower case fatality rate than what we're seeing initially, early in epidemics, things often look worse than they do later on. We learned that with H1N1, but really from a clinical point of view, they would be managed the same way and present very typically the same way.
The only thing I would add is that it appears that with COVID-19, the progression to sort of severe disease and pneumonia happens about 10 days after the onset of symptoms, which is a little different from MERS and SARS.
Different how?
It's just more delayed.
Slower, yeah, it's slower to come on.
And then there's a question about viral shedding. In our patient, he did shed virus in his stool on one day. He only had diarrhea one day. And it's, the CDC has been doing testing, and it seems reliably to be found in deep nasal samples in the throat. Hasn't really been reliably found in blood, and has intermittently been found in urine. So mostly it's respiratory samples where the positivity is reliably found.
Great. So how are we doing for time? 3 minutes to go. We can take maybe one more question.
So thank you. I think you guys are doing an amazing job with all this stuff going on. I'm curious what the false positive and false negative rate is for the testing.
So nobody knows.
Easy question. All right.
We asked the CDC that question, and we just don't know the difference in the assays in China versus what we're doing here in the U.S. So I don't know if any of the panelists have any idea, but it's unknown.
Sure.
Follow-up question. If we don't know how accurate the testing is, should we somehow treat it differently than if we knew how accurate it was? Like, should we do anything about that? I'm kind of curious.
Yeah, the testing that's being done, but based on looking for RNA, is actually in general a fairly sensitive assay. So, I'm sorry, Jeff.
Yeah.
So looking for 3 targets, and so the case definition. I don't know if you want to discuss, how many targets.
Yeah, so there are 3 targets, and Jeff, you'll have to remind me. I think 2 of them are like kind of conserved coronavirus regions, and then another one is the one that separates it out from the other coronaviruses. Is that right? So there's 3 targets, by the way. And so, I would think that 3 targets would make it a pretty good test, but yeah, we don't really have a panel for of positives and negatives that we know for sure that CDC can test. But that's part of the reason why it's really important to follow exactly what was approved, in the emergency use authorization, from the FDA. I mean, it was approved to test individuals with a higher likelihood of having coronavirus, which are people who have some epidemiologic link, essentially, to either China or a confirmed case.
Yeah, so I just add, if you start testing people in the general population as a very low pretest probability of having corona, then you're going to likely see more false positives, even for a very specific test.
Great. Well, anything else this panel that you absolutely wanted to say? We're going to have more time at the end for question and answer, but I do want to leave time for the other panels to take place. And you'll have a chance to ask questions after each of the panels as well. All right, I want to thank the panelists.
I want to be Jeff Ducci. Maybe so. So as our panel settles, I thought I'd just introduce myself. So as Judy mentioned earlier, my name is David Pickett. I'm an assistant professor here in the newly founded Department for Health Metrics Sciences, and I contribute to the university's MetaCenter for Pandemic Preparedness, trying to evaluate global vulnerability to outbreaks, trying to identify geographies where these new viruses could emerge from, and also health systems that are not so well prepared to respond and react and prevent transmission going forward. So the previous panel gave us a lot of virus names, things like Zika and Ebola that previously were rare diseases off in a far-flung country that are now becoming more common, being presented in the news on a routine basis and actually are part of day-to-day conversations more regularly. And globally, we are trying to better prepare. We've got a lot of organizations who now have it as their explicit mandate to think about global health security. So we have CDC with various country offices across the world. We've got Africa CDC now that's helping in many countries in Africa to kind of strengthen and bolster local preparedness. And we have overarching global legislation to try and understand and provide guidance for implementation of travel bans and quarantines that actually are supported by robust scientific evidence and allows for the Director General of the World Health Organization to declare something called a public health emergency of international concern, which this COVID-19 has now been declared. But that preparedness has not been uniform across the world. And even for health systems that are better prepared at a global scale, we're already seeing in China about 1,500 medical professionals have already been infected with this virus. So there's a lot that can be done. So I'm hoping in this session we'll discuss what's been happening locally over the last few years and how this has set us up to deal with the potential for incoming cases, and consider that within both clinical and community settings. And we'll discuss what response measures are currently warranted and how you can all pay attention to the information that you need to hear should that situation change going forward. So on the panel, I've got Dr. Janet Baseman, who's Professor of Epidemiology and Associate Dean for Public Health Practice at UW School of Public Health. She's led several research projects related to public health emergency preparedness and response as part of the Northwest Preparedness and Emergency Response Research Center, and she directs the Student Epidemic Action Leaders, or SEAL team, that contributes to supplementing state and local public health agencies with their real-time needs. To her left, I've got Jeff Duchin, who's prior to assuming the role of Health Officer for Public Health, Seattle and King County in June 2015. He served for over 15 years as Chief of the Public Health's Communicable Disease Epidemiology and Immunization Sector, and he was trained at the US CDC as part of the Epidemic Intelligence Service and served a variety of roles there prior to coming to Seattle. And finally, at the end, we've got John Lynch, who's an infectious disease physician at UW Medical Center, an associate professor of medicine at UW. He's the medical director of the Harborview Infection Prevention and Control program, as well as the Employee Health program, and leads hospital-based responses to infectious pathogens of all types. So I'd like to start off with Jeff, and I'd like you to, could you describe to us what local systems have been developed over the years to counter these newly incoming pathogenic threats? And what are the steps that have been taken in King County to prepare for any possibility of cases coming in?
Thank you for the question. Counter is a strong word. Any response to an emerging infectious disease is based on the capacity and the quality of the local public health and healthcare delivery system. And if you look at the international health regulations or global health security, it's all based on countries having good public health infrastructure, good emergency response infrastructure, and good healthcare system infrastructure. So to the extent that we in the US have, relatively speaking, a very good healthcare system infrastructure, there was recently a Global Health Security Index study in the US ranked at the top with respect to being able to manage a large-scale pandemic. That doesn't mean we would do it easily or do it especially well by our own standards, but we're at the top of the global scale. And Washington State ranks consistently at the top of US states with respect to emergency preparedness. And we're in a very fortunate county where we have a robust health department with lots of experts that are trained here at the university, and we have very good, long-standing relationships with our healthcare community, which is a very fundamental part of emerging infectious disease response. So, for example, 20 years ago, I started a group it was at that time called the Outbreak Response Work Group, where we brought together county hospital executives with our public health team to talk about things like bioterrorism and emerging infectious diseases. And shortly after we started that, the SARS outbreak happened. And that thing evolved into ultimately what became the Northwest Healthcare Response Network, which is an organization that's now statewide but started in the county, which brings together our county hospitals and our public health program to ensure an integrated and coordinated response to any sort of emerging disease threat or health emergency. It could be an earthquake, it could be H1N1 influenza, or it could be any other type of emerging disease threat. So I think what we have here in the county that is valuable is a long-standing history of very good relationships with our healthcare sector. John, I'm sure, will talk about some of the collaborations that we've had in the context of this new coronavirus situation. And we've got a, relatively speaking, on the global scale, well-funded healthcare system and public health sector. However, I can tell you that no public health system in the U.S. is adequately funded to meet the demands of something like a novel coronavirus outbreak or a pandemic flu. The funding doesn't allow for any meaningful surge capacity. We barely have the resources to do our daily work. And over the last 10 years, the federal funding for both public health and hospital system preparedness has been cut by 30%. So I'll leave it there.
Thanks. And John, switching to the clinical context, what have hospitals been doing to prepare themselves for potentially highly infectious patients?
Yeah, thank you. I'm sorry, I'm still reeling from Jeff's comments a little bit. So, hospitals want to care for people. They want to provide good clinical care for people across our country. And there's a bunch of issues that intersect with the issue of new epidemics. To some extent, we sort of deal with on a year-by-year basis. For instance, influenza right now, has killed over 60 people in Washington State, 5 or more children. And this is something we deal with on a regular basis. We've had people walk through our emergency department with measles. We know about the measles outbreak last year, and a lot of those people end up in healthcare facilities, and facilities need to be prepared for patients with flu, patients with measles, patients with mumps, and other infectious diseases on a regular basis. At the same time, we don't tend to have, as Jeff sort of pointed out, surge capacity. We're not built in healthcare systems to expand out and all of a sudden accept people with novel infectious diseases. And we need to be thinking hard about that. And we have been, as George pointed out. I think really the 2014 West African Ebola outbreak was obviously a hugely devastating epidemic for the people who were in West Africa who had to deal with that and lost loved ones and coworkers and so forth. But it was, to some extent, transformative for many hospitals in the United States, and particularly here in Washington State, in that we started training as if these folks could show up in our hospitals either expectedly or unexpectedly. They walk through our emergency department, they walk into one of our clinics, or we get contacted by our colleagues at public health saying, hey, we need someone to be evaluated. Since that time, we've done a lot of training. That training has been different at different hospitals. Some places like George's and my facility have done lots of training over the years. Other places have really, their training's been focused on, hey, how do we identify, kind of isolate, and then get this patient to another facility. And I can't say all of those things have been figured out despite a lot of training, right? How to transport someone across Washington State is actually not an easy task with a novel infectious disease. At the same time, we have to be prepared. And so a lot of work has been done at certain facilities in our state, I think done very effectively. And part of the thing, though, that keeps me, very acutely aware and concerned around this work is the fact that we have to sort of slot people into certain categories. I think Kathy mentioned earlier, we're thinking about this new virus as a droplet virus, right? This is something that people cough and sneeze and droplets go about 6 feet, and if you're within 6 feet, you may inhale them, and if you may touch it later on and then touch your eyes, nose, and mouth and get infected. That's a problem when you're in a hospital, right? It is a problem when you think that's the reason, that's how it gets transmitted, but you're not 100% sure. Because I have lots of patients in my facility. I have lots of patients who are sharing spaces. Our emergency department has curtains separating one patient from the next in a large part of it. And I have lots of healthcare workers who spend a lot of time at work. And I'll just point out, and I think this has been touched on just recently, is that SARS, MERS, and this new coronavirus have all preyed upon healthcare settings, preferentially. And that's actually quite true for Ebola as well. I work in the field of what's called healthcare-associated infection prevention. My job is to keep patients safe in the hospital. And we don't usually think about pandemics and epidemics in that setting. We're thinking about bloodstream infections and pneumonia and types of diarrhea. I would argue that these fall directly in that line with healthcare-associated infection prevention. These viruses are propagated by healthcare, right? And if we don't do it right, it actually drives the transmission of these. And we saw that in MERS. The biggest outbreak of MERS was in South Korea, not in the Middle East. And it was driven by healthcare. Nearly shut down the hospitals in Seoul. SARS in Toronto. This, let alone what's going on in Hubei province now, and specifically in Wuhan. And the same thing happened with the Ebola epidemic in 2014. So we need to be thinking about how to prepare for these things at any given time when we have no idea what's coming through our front doors. We need to be thinking about how we're going to classify them, because how we classify them sort of defines how we act and what precautions we take as healthcare workers and as patients. And then we need to be thinking about when that coordination is or put into play by our public health colleagues. And just a quick shout out, we have the best public health, local public health jurisdiction in the country, led by this guy.
I was just wanting to have an opportunity to say that we so much appreciate our colleagues at Harborview Medical Center. Seriously, when we needed a hospital to evaluate a possible Ebola patient, we called around and Harborview just jumped at it. It's like, yes, we want it, Ebola. And so, they are always there, and they do an amazing job, and they were the first to jump for this as well. And I know you talk about that home assessment team that John's leading, that
Jeff invented.
That's really innovative in helping us evaluate patients at home. So yeah, these guys are amazing.
So are those guys.
And Janet, how does the university help facilitate these excellent scopes of work?
No pressure. No pressure in the context of those remarks. So thanks, David. In case you didn't know, at the University of Washington, we have a student outbreak response team. It's called the SEAL team, which stands for Student Epidemic Action Leaders. It has been around for 5 years, and it's housed in our Department of Epidemiology in the School of Public Health. I created the program 5 years ago to serve two purposes. The first was to provide opportunities for our students who do a lot of work in the classroom to get out of the classroom and do some real, what we call boots on the ground public health work with their epidemiology skills as they're developing. And the second, which was equally important to me, was to actually provide some real value to our state and local public health partners. And in order to do that, I realized that we needed to train them before we just sent them out. So the way the SEAL team program works is that they are offered a structured curriculum. They spend a quarter with me before they're allowed to deploy to do anything at our practice partners agencies. And then once they're trained, they work on and off throughout the year, responding to a variety of needs from our practice partners. Some of them are real-time and kind of time-sensitive needs, and others are special projects that the agencies don't have the capacity to do on their own. They don't have the resources to complete them, so our SEAL students can come in and help with that. So typically, we're helping out with lower profile outbreaks, if you will. The SEAL students over the years have done a variety of different projects. They helped stand up a new disease reporting system for the Washington State Department of Health. They did research on what other states were doing with foodborne complaint reporting systems to report back to our partners. They've done a range of different projects. So the SEAL team is currently deployed to Public Health Seattle-King County, working with Jeff and his team, and they are assisting the public health nurses and epidemiologists who, as you just heard, are really strapped for time and spread really thin. They're helping out with symptom watch activities. They're supporting the epidemiologists doing some data system work and data entry work. And a group of SEALs just trained today at the State Public Health Lab in order to help with data entry needs that may become needed when the state stands up their testing capacity if there are samples to be tested. So just to kind of harken back to Dean Godwin's comments, her introductory comments, there's not a formula for the way a university can help out during a public health emergency. So we'd be contributing based on the existing relationships that we have already in place to the extent that that we are able. And all I can say is that I think being able to contribute some support, even if it's small, to our state and local partners through Student Outbreak Response Team model, I hope is a contribution in needed epidemiology surge capacity for our partners, and it just helps as a School of Public Health for us to be able to contribute anything, really.
Thanks. And actually, just before we transition to the general Q&A, I just want, John, if I could ask you, like we've seen a lot of discussion in the media about what we should do and what we shouldn't do, and often they contradict each other. What can individuals be doing on a day-to-day basis, and what are the reliable data streams that they should pay attention to see how that changes over the outbreak?
Wash your hands. That's pretty much it. And no, honestly, hand hygiene is incredibly important. We think we're washing our hands all the time, and we're actually not. We think about washing our hands after using the bathroom, maybe before we eat, but not the rest of the time. And so wash your hands frequently throughout the day. Alcohol-based hand rubs, open water, that all works great. And I think that's the most important thing. The masks and all that stuff isn't going to be the answer. So I can certainly answer more about that later, or if people have questions. So that's one. Two, media. I have to say that the folks, the media folks in Western Washington, I think, are actually really strong. And I think, Jeff's team and certainly our team and George and others have really been trying to participate and answer questions with them. And I think they've done a pretty good job locally here. I think I look at WHO for the other places. CDC is a good resource. Public Health Seattle-King County, including Jeff's blogs, I think are really also excellent. Department of Health has a very nice website that has very good data on it. So I think our local health jurisdiction, our State Department, CDC are all great. WHO is good as well. And I think that there are reputable news sources that are doing a very good job, including ours here locally.
Okay. So I'd like to open to the wider audience, but given that whilst people gather by the microphones, and given this is the 21st century, we actually had a question come in through Facebook. And that was related to, in China, we've seen quite a lot of extreme lockdowns and mass quarantinings and enforced quarantines. And some of the discussion has been seen, and decisions seem more influenced by fear and racism and xenophobia. And so, Jeff, how does that play into your decision making? How do we make sure that we're looking after anybody regardless of where they come from?
Yeah, so the issue of stigma is a big one. And previously when asked about this, I said, we have more experts here tonight than we have cases of coronavirus in the U.S. And so we don't want to have an outbreak of fear, stigma, racism, and discrimination when we don't have even an outbreak of coronavirus. And we have to be very careful about understanding the evidence and what the risk factors are for this disease is having contact with someone else who has the disease or traveling to a place where the disease outbreak is happening. And it has nothing to do with the way someone appears, what their national origin is, or their ethnicity. So that's something we really need to keep in mind, because there is a huge amount of discrimination and misinformation and stigmatization going on. Was that the crux of your question, or was there a second part to it?
No, that you're cognizant of those perceptions, and it's something that.
Yeah, you don't want me to get into the quarantine part of it. Okay, good.
Yeah. So over to the floor.
Oh, great, thanks. Do we know yet how long the virus can actually live outside of a host in a moist environment? And do we know if an infected person who has been infected and recovered, can they be infected again?
Okay, thank you. Could we accumulate some more questions, please, and then I'll hand it over to the panel.
My question is related to how you think about resource allocation at a local level. So if you have an outbreak like this that doesn't actually have that many cases in the U.S., how do you manage a department that doesn't have that many resources and still address resources that we have in King County or the state?
And over to the left-hand side.
So I have a question from an infection control nurse perspective, where our Achilles heel is always that people show up sick at work. And so for controlling the respiratory viruses, what are your suggestions for countering the culture in understaffed facilities where people show up sick, physicians show up sick, surgical residents show up sick, nursing homes show up sick, the well-intended but difficult?
So over to the panel, and we'll take some more after.
Can we go backwards? Sure. So to your question, I think it's actually really important. So, where I think a lot of us are familiar with the term absenteeism, well, there's presenteeism, and that's true, and that happens in a lot of industries, and it definitely happens in healthcare. A lot of healthcare folks across the spectrum of work show up to work when they're sick. And to a large extent, we have a system that's built to do that. There's culture, right? I think a lot of people work in healthcare because they want to show up and take care of people. But we also have a system of how we pay people that makes them come to work when they're sick. And we don't reward them for good behaviors around staying home when they're ill. And so I think that things around that are to build sort of cultural systems to support people when they're ill to stay home. For instance, our residents at my facility, our Department of Medicine residents, have a risk pool. And so if they're sick, they can go home, someone will cover them, and they don't feel like they're leaving their team short. As of July of this year, our Department of Medicine attendings, who are the people who run the teams, who are responsible for the patient care, they've never had risk. 2 of our attendings were sick with flu last week, so that's half of our attendings were out, and we had to find risks for them. And starting July at Harborview, we're going to have a risk pool for them. And so building those cultural systems. I think the larger issue of how we provide equitable leave and sick leave is a much more challenging one. And it's one that we need to address at a much larger level, because that's going to be companies and industries stepping up and making sure that their sick employees stay home and take care of themselves when they themselves or their family members are sick.
Can I add something to that excellent answer? So, if this outbreak appears here and there's a lot of community transmission and the disease is relatively severe, we're going to pivot as a country from this current strategy of isolating cases, tracing their contacts, and quarantining them to what's called community mitigation. And a big piece of community mitigation are what are called social distancing strategies. And social distancing includes don't go to school or work when you're sick. And so we would expect schools, workplaces, and healthcare facilities to start thinking now very seriously about how they're going to minimize social interactions among their employees, telecommuting, screening people, making sure people don't show up when they're sick, because they're going to put the rest of their employees at risk, and you're going to have to plan for absenteeism because some of them will be ill. So this whole idea of staying away from others, staying home when you're sick, don't be around sick people, but particularly in the context of continuity of critical operations in the community. People need to start planning about what's going to happen when up to a third of their workforce can't come in, and making sure that the people who are coming in are well, and making sure you have systems in place to put a mask on somebody who's sick in the workplace, isolate them from others, and get them home or to a healthcare facility if they need to go there, if they do show up when they're sick.
We had that question about resource allocation and what goes into those decisions. Like earlier we said that more people have died of influenza in the state at the minute. Like, how do you make that trade-off of different pathogens, different diseases and things?
Well, this is really a global health emergency. It's not a tough decision for us. This virus represents the next potential pandemic virus or illness to affect many countries. It already is affecting many countries, but none as severely as China, and relatively limited transmission so far to the extent that we know in most other countries that have reported cases. But it has the potential to move very rapidly to many other countries and cause high levels of illness. So we don't have any reservations about dedicating large numbers of resources. In our small department, we have over 100 people working on our outbreak response right now. People have been working for 3 weeks with very little rest, and we're very much grateful for and dependent on some of the help we're getting from Janet Seals and from some of the other volunteers that have stepped forward to help us out. But we have to stop doing some of the other things that we routinely do, although we have a very important other outbreak happening now. We have a hepatitis A outbreak that's happening among homeless injection drug homeless and people who use injection drugs. We've also got an HIV outbreak among heterosexual injection drug users. We're not stopping those activities, but there are a lot of other things that unfortunately we're taking staff from who can't do their usual work at the moment. So we'd like to have more staff, but we do the best we can with what we have.
Can I just add on that just a little bit, is that the resource allocation around public health is incredibly important, but the impact, and George sort of hinted at this, the resources needed right now to take care of a patient with this infection in a hospital are huge, right? George is talking about isolation units, all the PPE, in their case, using a telemedicine sort of robot. As it stands right now, that's going to be the response of any institution, any hospital that accepts a patient with suspected, right, or known. And suspected could last days because it takes us 3 to 5 days to get this test back. Huge amounts of resources. And there's going to be a period until we come to this, social mitigation sort of strategy where we accept this may be an endemic sort of circulating virus, where we're going to be spending huge amounts of resources in the public health sphere, but also in the healthcare resource sector or the healthcare sector, where we're going to be having to stand up biocontainment and dedicated healthcare teams in many, many places. And that is a unanswered challenge.
And then the touching back on that first question, what evidence or epidemiological information do we have on how long the virus can persist, or whether recovered individuals can infect others? I haven't heard of anything yet.
So, I've seen some scatter reports around coronavirus persistence in wet. So, how moist is moist? It's like there's a lot of levels of wetness. So if it's dry, it's not a hardy virus. It goes away. All the normal disinfectants kill these viruses, so they're very easy to kill. And I think they don't persist on surfaces unless they're maintained wet. And I think if they're maintained wet, I actually don't know what the top end is. It's probably days if that moisture is maintained over those days. Do you guys know more?
No, there have been a few studies of coronaviruses, and depending on the type of surface also, smooth, shiny surface is better than a textured surface to recover, viable virus from. It can be from minutes in inhospitable surface and conditions to days. But these are lab experiments. It's not real world, so it's kind of hard to generalize what that means.
And the next bill may be able to answer the reinfection question better. I think you can get reinfected. What's that? It's early days. Early days, yeah.
Okay, I think we've got time for 2 quick questions, one from each side. So,
hi, I was wondering if we have a definitive value for the R0 or for the viral load needed for infection through transmission? And if we do, could you put that in relation to other infectious diseases we've seen in the past?
And over there.
My question is about cruise ships. They say if the cruise ship off of Yokohama's country, it would be the second biggest number of coronavirus cases. Are there discussions going on with you guys and the cruise ship industry, which seems to be quite popular here, on what happens if you have a coronavirus case on your 1,000-boat?
Okay, or not. Well, no. We don't really know what the transmission characteristics precisely. They're estimates, but they're based on limited data, and we don't know, the true spectrum of infection yet, and how many mildly or less severe or even asymptomatic persons there are. So the estimate is still, based on the data that are available, around the 2 range, which is relatively high. When influenza, influenza viruses is like a 1.3 in general. So this would be more communicable than flu. But R naught really is another thing that doesn't really tell the whole story, because it's not just how many people an infected person can spread to, but how many opportunities might that person have to spread, and that's dependent on the structure of the community and the society, and how quickly that person might get into isolation or treatment and other factors that would limit spread. So I would say it's a work in progress. And what was the other question you asked about besides
Viral load.
Oh yeah, viral load. Yeah, no. I don't think people know yet what the true transmissibility is, which is what you're getting at with viral load. With respect, there are an increasing number of case reports of asymptomatic persons spreading the disease, but how common that is not clear. It's probably not very common, but I think it probably can happen.
Is there anyone with a quick comment on the cruise ship situation?
So the cruise ship, that's a disaster. The Diamond Princess, that was a real good example of how not to quarantine and how to do it in a way that is not really ethical. You're not supposed to put people at increased risk when they're under quarantine, in any case. Yes, we're working with the cruise ship industry, which is really the CDC's responsibility to deal with the maritime industry. They're discussing this very actively with cruise ship industry. We're interested because we have a big cruise ship business here. Very happy it's not cruise ship season right now, and I imagine it would be handled a lot like we handled the airport. It's a port, it's a vessel with people on it, and we'll have to, the captains of the boats, just like the captains of the airplanes, are obligated to report when there's somebody ill on the vessel, and then it's met by CDC folks who will do screening, and they'll say, oh, if there's anything wrong, let's call the local health jurisdiction to take this person away and deal with it.
The Coast Guard did ask if the Harborview Home Assessment Team would be willing to be dropped by helicopter onto a ship if needed.
Yeah,
we said yes.
And with that insight, I think we're going to switch to the next panel session.
Are they going to fast track?
I think I answer video will do it. Okay.
Hi, everyone. Can you hear me? I'm Wes Van Voris. It's been a long time since I was introduced, but I'm part of the MetaCenter for Pandemic Preparedness. I am the face of the geeks. The geeks always come last, right? And these very handsome geeks are here to talk about University of Washington innovations and talk about the innovations that are going on to address the coronavirus, the novel coronavirus. And I just want to shout out to the MetaCenter and Judy and Peter for organizing a group of centers. I think it's 8 different centers that come from around University of Washington and coordinate pandemic responsiveness in a really interesting way, including groups around climate change. You heard about Peter's group that works on zoonotic interventions, the IHME that coordinates trying to predict where the next pandemic's coming, and so on. And we represent the biomedical interventions groups. Each of these people has a tie to the MetaCenter, but I want to talk just for a moment before I introduce them about what else is going on at University of Washington for those folks that are running around the world trying to address the novel coronavirus. And this includes Michael Gale, who runs the Center for, I always have to look up the word, actually it's Center for Innate Immunity and Immune Diseases, and Michael's lab is working on how the coronavirus subverts our own immunity. So you probably don't know, for a virus to succeed, it has to tamp down our own basic cells, eons of resistance to viruses, and coronavirus, the novel coronavirus is obviously doing a good job on that. It's tamping down our resistance and able to get transmitted from person to person. Mike Gale is a star at figuring this out, and I'm sure he'll come up with interventions that'll work both on the host side, meaning the human side, and on the virus side to help us with that. Paul Yeager, who isn't here, who represents the Center for Diagnostics, oh, he is here, he's waving over there, is working on a novel RNA virus. So the novel coronavirus is an RNA virus. Dr. Yeager has cutting-edge biomedical engineering technology that allows us to detect very few RNA viruses in our secretions and so on. And the dream is to have a home test where this can go forward actually for the novel coronavirus in a relatively short amount of time. And then the Center for Emerging and Reemerging Infectious Diseases is working on a variety of things, including structures of all the 25 different proteins that work with the RNA to make the packaged virus. We're working on coordinating with other groups around the world through a new group called UWARN, United World for Arboviral Research Network, that includes people that are in Taiwan. They're fighting this disease now. We're working with groups that are making things called neutralizing monoclonal antibodies. So we all make antibodies to viruses, and some of them stop the viruses from replicating. And we can actually clone those antibodies and produce them in a massive amount. And in other viral diseases, they've been shown to actually tamp down the viral diseases and lead to better outcomes. So we're working on that with collaborators at Rockefeller University. And then groups at called the Seattle Flu. How many of you have interacted with the Seattle Flu study this year? I know I've sent in my swabs. Quite a few in the room have. They're part of the they're part of the Brodmann Beatty Institute, and Helen Chu and Trevor Bedford lead that, and they're coordinating with public health. They've got this great network going through collecting virus samples and so on throughout the city and throughout the Puget Sound, and hopefully they're going to come up with great help for the public health to understand the transmission of this virus if it takes off in the Puget Sound area. Alex Greninger from Laboratory Medicine has worked up a new homegrown sort of detection kit and is helping us spread it to our international partners. And I could go on, but I won't, because now I need to introduce our guests. So our guests today include David Baker, who's the Henrietta and Aubrey Davis Endowed Professor in Biochemistry. He's the director of the Institute for Protein Design, where they figure out, proteins are the building blocks of our cells. But David Baker is the world's champion at figuring out how these things fold and how they interact with other things. And he's going to save us for all things in that. He's also a Howard Hughes investigator, and I think he's an adjunct professor in about 3/4 of the different departments that are at the University of Washington, and yet he looks 12 years old. So our next distinguished person is Deborah Fuller. She's a professor in the Department of Microbiology at UW, and she's also the division chief for infectious disease at our wonderful primate center here at University of Washington. Dr. Fuller's group is developing new and rapid response candidate vaccines. She has 3 different candidate vaccines already in mice, and hopefully they'll be into humans soon. And then David Wiesler is an assistant professor of biochemistry. He is the coronavirus dude. He has solved structures of coronaviruses, including SARS and MERS, helps understand how they enter cells and leave cells, and really what is the neutralizing activity of antibodies. So with that, I'm going to ask our panelists questions, and I'll start out with David Baker. And the question to you is really, we've talked about this tonight, about the diagnostics that are available for COVID-19. And can you tell us a little bit more about the one that's available now, and what are we really needing?
Yeah, as was already alluded to, the current test is an RT-PCR test. It's looking for the RNA of the virus. And we've heard about the problems in that it's only being done at the CDC, and there's a 5-day turnaround, which is clearly much too long. So we need tests that can be run locally and where results can be back, ideally point of care tests, and the kinds of things that Paul Yeager is working on could make a huge difference. The other thing that we need is not only to detect the virus itself, but detect antibodies that we make against the virus, and that will help with understanding the epidemiology. There's some people who will get only very mild infections. They'll make antibodies, so you won't be able to detect the virus, but they will make antibodies. So in terms of tracking how the virus is flowing through the population, that would be very useful.
Thanks, David. And David Wiesler. So the Everett patient was treated with a drug for coronavirus. Why was that drug selected, and how was it thought to work on the novel coronavirus?
So this drug is actually a nucleotide analog, which means it looks like the Can you hear me?
Really
now?
Close.
Cool. So the drug is a nucleotide analog, which means it looks like the building blocks making the viral genome. And when incorporated, it inhibits viral replication. It inhibits the polymerase of the virus. And it had been shown over the past couple of years, including very recently, that this drug is inhibiting SARS and MERS replication in vitro. It also inhibits replication of viruses related to SARS and MERS. And it had been shown in vivo, in mouse, ferrets, and in macaques, that the compound is inhibiting the virus. If given before infection, the compound prevents disease, and if given after infection, it decreases the viral load. So it was very promising. I think it made a lot of sense to try it. The polymerase is highly conserved in SARS-CoV-2 and SARS-CoV-1. And well, although we cannot say based on that one case if it was useful or not, at least it didn't seem like it was toxic. A promising result as well is that passaging of the virus, SARS-CoV or MERS-CoV in vitro with that compound actually led to the emergence of a couple mutations. But despite that, the virus was still neutralized by the compound when provided a high concentration, and the mutant viruses were attenuated in terms of fitness. So it looks like there is not that many solutions based on this limited data.
Great, thank you.
For the virus to escape, sorry.
And Dr. Fuller, so several groups have announced that vaccines to prevent COVID-19 could be made as quickly as a few months. What are the positive aspects of a vaccine being available so quickly, and what are the possible risks of rushing to a viral vaccine? Yeah.
Yeah, well, thank you for having me. For infectious diseases in general, and especially for emerging infectious diseases, the most effective way to stop that is through a vaccine. And so, when we hear about an outbreak, as a vaccinologist, we immediately get to work. And as Wes has pointed out, we already have a number of candidates already in our lab that are cooking and that we are investigating. And so, what happens is that, let's say next Friday, we discover one of these candidates really works. So then what comes next? It's not like the movie Contagion, where the scientists discovered the vaccine, and then the minute she did, she inoculated herself. That's not how that works. So vaccines have to go through a rigorous testing of safety, because the point about a vaccine is that it has to have minimal risk and maximum health benefits. So you can't put a vaccine out there that might actually cause problems. Is it going to be safe in immunosuppressed? Is it going to be safe in children? We need to determine that. So when you hear that somebody has a vaccine, but it's going to be months or even a year before it's actually being made available to people, that's why, because it needs to actually be tested for safety. So with that said, our researchers, including my lab, are really interested in trying to accelerate their process, mostly by accelerating the discovery process, accelerating the manufacturing process, and seeing if we can actually get vaccines out there quicker to be able to have intervention against an emerging pandemic. And so there's different ways that could actually work, where we might actually have, say, a candidate vaccine ready in months that could be actually initiated and tested in humans by accelerating, for example, the production of that vaccine. Other ways that we might look at is there's other groups that have developed a related vaccine, already is in the process, say a vaccine for a related coronavirus, and we're just going to check to see maybe that one's actually going to be effective against this particular type of vaccine. And then once you get a vaccine and it's safe, say in humans, how are you going to produce millions and millions of doses to vaccinate millions and millions of people? Well, you're not going to do that. What happens in an epidemic is you're going to produce just enough doses to vaccinate your first responders, your medical community, the people close to the people who are infected. You're going to build a ring of immunity around those who are infected. It's called ring vaccination, and it's a very effective strategy to help contain and control an epidemic. So those are sort of the advantages of getting a fast vaccine, but also the risks we have to worry about as well.
Thanks very much. And David Baker, how can you describe the Institute for Protein Design's response to this? And I know you're working a lot with Dr. Wiesler, too, on this and his structural insights.
Yes, so at the Institute for Protein Design, we're developing computational methods for creating new protein therapeutics that would, in the case of coronavirus, block the virus, new vaccines that could present the viral protein in a way that would cause your body to make a stronger immune response. We're also working on strategies towards diagnostics, some of them with Paul Yeager here. And the basic idea is that all of viruses are made of proteins, so is our immune system. And as we have understood more and more about how proteins work, we can now, on the computer, design new proteins that, as I said, block the virus. In that specific example, David's group is determining the three-dimensional structure of the virus. And so then what we do is design on the computer small proteins that can fit very snugly against the virus and are chemically complementary, so they bind very tightly. We've worked working with Deb on the flu, and in that case, we've designed such binders, and Deb's group has shown that they protect animals from the flu, and we're hoping to be able to do the same thing with David on coronavirus. And so the exciting thing about being able to do things on the computer in the context of a pandemic is, in principle, it can be very, very fast. Our computational methods still aren't perfect, but as they get better and better, we should be able to respond to pandemic or emerging threats much more rapidly than is possible now.
Thank you. Yeah, and Deb Fuller, will you describe, you're making primarily DNA vaccines, as I understand it. Can you explain to the audience how DNA vaccines might come forward quickly and how they'll be helpful for vaccination for the novel coronavirus?
Yeah, DNA vaccines really emerged a number of years ago, and they immediately showed promise for potential rapid response for emerging infectious diseases. But let me explain to you very quickly what a DNA vaccine is. I think most people are familiar with, for example, the flu vaccine. That's what we call killed vaccine. You take the virus, you inactivate it, and you inoculate it, and you generate an immune response. The other most popular type of vaccine is a live attenuated vaccine, like the measles vaccine. That's where you do genetic mutations in the virus and weaken it to a point where it won't cause a disease, but if you inject it, you'll get an immune response. The third type of vaccine commonly used is called just a protein or subunit vaccine. That's like our hepatitis B vaccine. It's just a very small component of the virus that's produced as protein and injected into your body to generate an immune response. A DNA vaccine is most similar to that protein subunit type vaccine. What it is actually just the genetic material from the pathogen. It's a DNA representing a small portion of that particular virus. And instead of having to go through the long process of manufacturing, purifying, and producing the vaccine, instead what we do is we take that genetic material and we micro-inject that into the cells of your own skin. So you become your own factory producing your own vaccine. And that shortcuts the process of actually having to produce a vaccine and go through a long process of purification. DNA vaccines are very cheap to produce too. You can produce large quantities of DNA very quickly. And so those are the types of candidate vaccines that we're currently testing in our laboratory, actually in collaboration here with these two Davids as Wes has indicated. It's interesting, when I first decided, I said, I think we could actually make a vaccine for this coronavirus. I immediately contacted Wes and I said, do you know any coronavirus dudes? And he introduced me to Dave. And of course, I'd already been collaborating with that David. And so UW's really great that way because we are very highly collaborative. And when there's, a new, epidemic or a new thing that needs to be addressed, we all kind of get together and we start putting our heads together and work. So hopefully, we'll be seeing something come out of UW soon.
Time's getting short, but I'm afraid we're going to have to cut off audience questions on the group. But I wanted to ask one final question to David Wiesler, and then I think we're going to have to turn it over to Beth on the standpoint of time. So, David, there's a lot of talk about viral structure and neutralizing antibodies and so on. How's that really going to help us with understanding the response to the COVID-19 situation?
Structures are important because they provide a blueprint for designing vaccines or therapeutics. Can you hear me? So structures are important because they provide a blueprint for designing vaccines or therapeutics. And we and others focus on the spike glycoprotein, which is the protein displayed at the viral surface that mediates attachment to host cell and entry. And this protein is also the main target of neutralizing antibodies upon infection. So if you understand what this target looks like and how antibodies binds to the target and neutralize viral infection, this is the first step towards a solution.
Great. Well, I'm very sorry to cut off the discussion. We've run a bit over time, but I want to make sure there's time for Beth to come up. I want to thank you guys very much. And I talked to these folks, and they're willing to stay behind and talk to you guys and answer your question afterwards. So at this point, do I turn it over to Beth? Yeah, to Beth. Thank you very much.
Thank you. Good evening. There will be time for some more questions in just a few moments. I wanted to thank all of you for coming, and I would like to just start off here by I have the great opportunity here to introduce our last speaker before me, who is a longtime friend and colleague of mine. You've heard here of it from lots of different groups at the UW that have been collaborating and working on how to understand this new virus and how to respond to it. And it's not just the university, however, and as you can see, this requires a huge effort by many different people. And so I'd like to introduce Dr. Scott Dowell, who is from the Gates Foundation, and he is the Gates Foundation point person on the new coronavirus. And he's been kind enough to come tonight to tell us a little bit about what the Gates Foundation is doing to help understand and respond to the coronavirus. And then after that, we certainly will have some time for some more questions. Scott.
It would help me if I could ask a favor of a show of hands of people. If you believe that this, having heard all this about the coronavirus, do you believe that this thing is coming here to Seattle? that we are going to see community transmission, and that the patients are going to fill up the ICUs in Harborview and other hospitals? Okay, the hands went down. So how many people believe it's coming here and that we're going to see community transmission? Maybe a third. And how many believe that it's going to have such an impact that the ICUs are going to be filled up with patients? And that's sort of that's my gut has told me, is that there's this intellectual recognition that this is a dangerous virus and that it might spread, but in our guts, and I put myself in the category of most of you too, that I'm not sure I believe it with my gut that it's coming here, but when I look at this intellectually, I can't imagine why it wouldn't. I've been doing this for a long time, and this is the fastest moving, most threatening pathogen that I've seen in 20-some years. And if I have I just wanted to give a story about why the Gates Foundation has committed, and I want to start with Li Wenliang. Do you know who Li Wenliang is? A couple nods. He was one of the ones who first described this. He was a brilliant student. I guess he scored 690 on his qualifying exam. I'm not sure if that seems like a high score to me. It got him into medical school at the Wuhan Medical School. And, in China they say if you're a 1 in a million, there's 1,000 more just exactly like you. So that's pretty good. He trained in ophthalmology. He got married, had a baby, and in December noticed on a lab slip that it was SARS coronavirus. And it was in the context of this cluster of viral pneumonias that were in the hospital. The slip got corrected later that it wasn't SARS coronavirus, but it was a related virus, and eventually became this novel COVID-19. He went on social media and told his medical school classmates, hey, watch out for this thing. I'm seeing these patients, and it's pretty dangerous. He was brought in by the local police and made to sign a statement acknowledging that he was doing illegal activity by posting this on social media. He went on to continue to take care of patients, including one with glaucoma who had this disease, and he thought that's how he got infected. He got sick. He checked himself into a hotel room because he didn't want his wife and baby to get infected. He got sicker. And a subsequent social media posting shows him with an oxygen mask, looking kind of grim. And then I was shocked, a lot of us were shocked a few days later when we heard that he had died of this infection. 34-year-old ophthalmologist who died with this. To me, those individual cases are what tell us this is not your normal influenza. I mean, we just don't hear about influenza killing the frontline doctors who are taking care of it. The next guy, the head of Wuhan hospital, died yesterday of this, 51-year-old, otherwise healthy person. So the early stories that this wasn't transmissible person to person, that it caused mostly mild disease, that it was a risk if you were elderly or had an underlying condition, many of those have proven not to be true. And so when we looked at this, and we've been following it for several weeks, we look at two main things that I think are alarming. One is transmissibility, and you've heard about R0, the average reproductive number, which is estimates center around, around 2.5, but that's robustly transmissible human pathogen. And it's different from SARS and MERS in that it's transmissible early in the symptomatic period. So this is not a hospital-transmitted pathogen, community-transmitted. So alarm number one. And number two is the case fatality risk, which is substantial. Again, you hear estimates anywhere from about 0.4% up to maybe 1.5%. After you factor in and decrease the artificially elevated 2.5%, that's the crude right now. In any case, keep in mind that a normal influenza season, about 0.1% die. So this is 4 to 15 or more times more severe than influenza season. It's in the category at least of the 1957 flu, and perhaps a little bit beyond that. So combine transmissibility and severity, and we're concerned. The Gates Foundation committed $100 million to this global effort about 2 weeks ago, and we've been scrambling to figure out how to use that most effectively. maybe two things before I end. One, we were in Geneva last week with, there was a global convening of all the public health leaders around the world who are working on this, and it's quite clear that Dr. Tedros and the WHO leaders are all in on this. They're working around the clock, and that the research community is working around the clock and really moving products forward at a pace that's never been seen before. So that part's encouraging. Our 100 million, three buckets. First, 20 million for detection and containment. This is money that's going to go to China CDC, to WHO, and to others working to identify those cases, isolate them, and contain them in an effort to slow the thing down. Number two, 20 million to protect the most vulnerable. In Africa and South Asia, the impoverished populations, we know from previous epidemics, they're always last in line. When a vaccine comes along, when a therapeutic comes along, they are going to be last in line. And so the foundation is going to do what we can to make those things available for them. And then number three, 60 million for product development, especially antivirals, but also vaccines and diagnostic tests. And that's an implicit signal by the foundation that we think we're in this for the long run. It takes a long time, as you've heard, to develop products, but it's worth it because if this thing is going to be around for a while, and we think it may be. So I'll stop there. And
thank you. Sit over here. Thank you, If I could ask all the panelists to come up, I think we actually have enough chairs for everybody. And if those of you who are still here and appear to be still listening, which is we're very happy to see, if there are some additional questions, we certainly can take really questions about pretty much anything we've covered and anything else you'd like to hear about from our panelists. We have a few minutes before we need to close. Oh yeah, okay. Thank you. Okay, please.
We've heard recently that many people who don't have health insurance go to emergency rooms and then get gigantic bills, and some of that is from the emergency rooms being run by private industry who the hospitals give a contract to. So I'm wondering, who's going to pay for all this treatment? Because you don't have surge capacity, you said, and the medical people are going to get sick themselves. So where is this going to come from, and why would people go to the hospital if they're going to get a big bill and die anyway?
Thank you. Okay, we'll bundle, I think. Oh, go ahead from the other side.
Yes. Hello. Thank you, guys. So there was unfortunately no one from the alternative medical field in our panel. I happen to be a naturopathic physician, and I'm an adjunct faculty at Bastyr University. So I am very interested in epidemics and pandemics. So I've been researching the area, figuring out if there are any potentially effective alternative therapies for epidemics and pandemics. And I know I don't really fit in the audience whatsoever here. I'm totally alternative. But I just wanted to say thank God for conventional medicine. But there are alternative solutions to prevention and potentially treatment of epidemics and pandemics. And I have given a talk at our National American Association of Naturopathic Physicians Convention just this last August. My talk is on my website, which is drsharif.com. It took years to prepare that, and I'd love for one of the experts here to potentially consider alternative therapies for this epidemic. Thank you.
Thank you. Okay, one more question, and then I'll pass it to the panel.
How many concurrent cases of coronavirus do we have regional capacity to treat in sort of in the isolated way that we saw done up in Everett?
Okay, great. All right, so you guys are going to have to pass the microphone around. So we can start with the last question, which is about surge capacity. And how are we fixed for taking care potentially of a large number of ill patients? George, go ahead.
Yeah, so I was just talking to John about this before we met. So in Everett, we're ready to accept 10 patients right now, and we're looking to sort of fit our 10th floor of our hospital to take up to 60 patients. So I think that's probably where we would max out locally.
So you would say you're maybe the largest referral hospital in Snohomish County, for example? Okay, so go ahead.
Yeah, I mean, like right now, I could have 2 people roll right in, and by tomorrow, we could probably have 40. But that would, just to be clear, would, in my facility, be displacing a lot of other patients, and it wouldn't be at a biocontainment level. It would be a facility, 30 or so rooms, shared spaces, negative pressure, where the whole unit is turned over that way.
Would one of you Jeff, yeah.
So back in 2006, we did some modeling to look at what a severe 1968-like and a 1918-like pandemic would do to our healthcare system in King County. A 1968-like pandemic would require 40% additional hospital beds. So that means the hospitals, would have to find another 40% of their beds, which is huge. A 1918 would be over 200% of hospital bed capacity needed. So no healthcare system in the world is able to meet that demand without drastic changes in the way we deliver healthcare, crisis standards of care, and alternative care delivery models.
Any other panelists want to say something about surge? Go ahead, Scott.
For perspective, in Wuhan, they built 2,000-bed hospitals in 10 days. Yeah. They shipped in 36,000 doctors and nurses from around China. 10% of China's intensive care capacity went to Wuhan to take care of it, and they're still overwhelmed.
Can we order a hospital?
All right. So the next, the question, there was another question about our healthcare system and payment for medical care for uninsured patients, and how that will be dealt with such that it's not an impediment for people seeking medical care who need it. Anyone want to comment on that?
They can come to Harborview.
That's right. They can come
and they'll
to
come
Harborview.
and they'll come to Prov Everett, and we'll provide the care for them.
Medicare for all.
Okay. Right. All right, and
Well, just to be clear,
go ahead.
I think a lot of the hospitals, all the hospitals in our region will do that.
It's an interesting point that of communication for people to actually. I guess you don't want to broadcast that. On the other hand, it would be good for people to maybe know that. And anyone want to make a comment on alternative therapies of any sort? Okay, appreciate the comment. Go ahead.
So I have a question. I do simulation-based things.
Use your microphone.
Thanks. So I do some research on helping people think with simulations. And one thing I was kind of curious about, I'm guessing I'm wrong, and you guys will correct me, which is great. I see a lot of these fatality rate estimates. And most of them are kind of based on some set of past data and or potentially very unreliable data sets. And so my question is, when you estimate these things, do you correct for, the gentleman who leads up these responses saying that, we just don't have surge capacity, and that if so many people need, let's say, ICU treatment, that we're going to eventually stop being able to give that to them, and then their fatality rate is going to start going up from if they had gotten that care. And so I'm curious how that's taken account of. And
so the question is how you correct for.
So if we had a real, let's say, 1918 flu pandemic scenario, and we go over capacity, the fatality rate's potentially going to change from earlier on in the pandemic when we're below capacity.
Fatality rate. Yeah. Okay. Go ahead.
Thank you so much for your talk. My question is that, what do we know so far about what causes or might causes the pathological change from mild symptom to very severe pneumonia, and also like respiratory degradation? And also like in China, ECMO is used as the last resort. And what is the current protocol right now in US for severe treatment? Thank you.
Okay. We'll take both of you guys quickly, and then we'll answer those questions, and then I'll close the session. Go ahead.
I want to thank everybody. It's just amazing. I was so excited to see it. I do a lot of work on Twitter. I'm an emerge.com tech specialist and a Twitter architect. So I'm seeing a lot more detail than probably the average person would. So I want to thank you, because you're really leading edge, and thank you for opening it up to everyone to have specific questions. And a very sad announcement of just two passings from the Diamond Princess. They're both in their 80s. And another 50 cases today in South Korea. So the trend is going there. I'm seeing clusters from the French Chalet, the Six, the taxi drivers had a big party on a houseboat, so we're seeing the taxi driver cluster. In Japan, we're seeing the churches clusters grouping, and I was just so excited to read the detail of the first patient report, and I would like to ask, how fast can we get the experimental antiviral that was used for our first patient? And congratulations on doing such a great job for him and following up.
Thank you. Okay, last question. Make it a good one.
Oh, geez. My question's about, so how does sort of commercialization strategy change for something like an RDT or a point-of-care diagnostic, or even vaccines, when what you're treating is a pandemic as opposed to something like malaria, which there's going to be a long-term market for?
Okay, good, thank you. All right, so we'll go back to the first question, which is about case fatality rates, and the question of how the case fatality, what are the various problems with calculating case fatality rate, how the case fatality might change over time as the outbreak proceeds, as different sorts of groups get diagnosed, and as the numerator and the denominator change. Would anybody like to sort of comment on that issue?
Sure. I think the biggest challenge with the case fatality right now is probably figuring out the denominator, because there may be many people with mild illness who would never present to care and never get tested, and we just don't know about them. So yeah, the numerator I think can be challenging as well, but I think the big challenge right now is that denominator.
Okay. The next question has to do with risk factors for severe disease and what we think about ECMO.
Severe disease? You saw him.
Yeah, so I mean, the general risk factors are going to be patients that are elderly and have a lot of medical problems. Those are folks that are going to be at most risk for severe disease, and as we've seen, it does affect younger folks that are healthy as well. But I should also mention that it appears that the disease in children is actually quite mild, which is actually quite fortunate as well.
I would say just this issue of ECMO or extracorporeal life support is sort of a last-ditch effort. When people's lungs stop working, you can basically put people on a bypass. And we have capacity for that in Washington State, but we often, even with flu this year, have tapped out. We've had 4 patients at my facility, and at that point, we cannot do any more. And that's just patients with influenza. And then most other facilities around the state, it's 1 or 2 patients. I don't know how many you could run at your facility, if any.
They go to Swedish.
They go to Swedish, and I don't know how many they can take. So if we get to this point, like as they're dealing with in Wuhan, we don't have the capacity to deal with that level of need. And I'll just be clear, if people who need ECLS or ECMO don't get it, they die. There's no other option for them.
So another consideration for surge capacity, I guess. Okay, and I'm going to take the moderator's prerogative and put the last 2 questions together, and they have to do with the availability of the current antiviral that was tried once, and what the plans are for that, and then the larger question about how to make antivirals, vaccines, diagnostics commercially available, especially in the setting where the usual economic drivers and incentives for that sort of thing are perhaps not what they would be for, sort of a disease that we would expect to be around for a very long time. So would anybody like to respond to any part of that? Deb?
Yeah, I can respond a little bit to development of vaccines, and this would have to some extent a new antiviral that would be out there. Is that when we think about commercialization of vaccines, as I alluded to before, it usually takes quite a process that brings you all the way through various phases of clinical trials as well as animal testing, and that can take up to a year. A number of years ago, the CDC and the World Health Organization and others came up with a plan that in the event of a crucial pandemic, that we could potentially shortchange that particular process. And one is called the 2-animal rule, which means that you'd have to show that your vaccine or antiviral works in 2 animal species, like a mouse and a monkey. And then the third phase would be at least to show it's safe in humans. And so then with those established, you could actually shortcut things to get things into the population quicker. But even with that, we want to focus primarily on first responders and medical teams and people closest to those who are infected. So you want to try to avoid more vulnerable populations such as children and immunosuppressed individuals to help to control the goal would be to control the epidemic, not necessarily get the vaccine or the antiviral into everybody. So,
Scott, you want to say something about that? Go ahead.
Yeah, just I don't want people to leave with the impression that remdesivir is the only antiviral. There's several dozen compounds that are being tested that are already marketed compounds, and there's another library of 14,000 compounds that can be screened through. So there will be lots of candidates, antivirals, that lots of groups and people are going to try and move through quickly. I'm actually impressed, maybe optimistic about vaccine possibilities. There are 48, I think CEPI put out a call for coronavirus, COVID-19 vaccine candidates. There were 48 applications that came in and were reviewed overnight last night by a whole group of people. So there's going to be lots of choices, and but the question is really good about commercial markets. Who will pay for this? Will the usual commercial markets come in, or will we need a separate funding facility to get the vaccines to those who need them? Those are all unanswered questions in a very fast-moving environment. It's quite possible there'll be a commercial market. It's quite possible there'll need to be some sort of public funding mechanism to make sure that those in Africa, South Asia, and elsewhere who need these things will get them. But watch this space. Lots of unprecedented things are going to continue to happen.
Thank you. Okay, well, my timekeeper is showing the 1 minute remaining. I don't know based on what, I'm not sure since we're already over, but I would like to just take this opportunity to again thank you all for coming and say, like many of the people that you've been hearing from, I've been doing this for a very long time, and I think one of the hardest parts of it is the uncertainty and the fact that the situation changes and we learn more and the facts change. And so in that context, I think not freaking out and educating yourselves as best you can as you're doing. And for those of us that are working in this space, as you can tell, we're working very hard. One of the things that the MetaCenter we've been hoping to facilitate is people working in this area talking among themselves and sharing information, and this is kind of one effort in that regard. I guarantee you that things will change. I think that as Scott is saying, I think that the landscape looks pretty good for things like vaccines and antivirals. But there are many, many challenges, and we don't know what's going to happen. So in that context, again, I want to thank you all for learning what you can, and stay tuned. Thanks a lot for coming.
Thank you.